Every healthcare system is really a story about people moving through care. This is a digital twin of that story, an entire cardiology pathway, brought to life. We start by configuring the pathways this service actually delivers. Rapid access chest pain. Rapid access heart failure. Atrial fibrillation. Every hospital is different, so nothing here is fixed. You define referrals, demand, diagnostics, procedures, and discharge outcomes, pathway by pathway. That flexibility matters, because a model built for one trust rarely fits the next. This one adapts to yours. This is where planning comes in. A new medicine entering the pathway. New diagnostics. Extra staffing. Weekend clinics. Strike action. A change to referral patterns. Each becomes a scenario you can test, properly, before a single change happens in the real world. That's the difference between guessing and knowing. Workforce planning here isn't a headcount spreadsheet. For every pathway, you define staffing proportions, consultation durations, staff types, and workload. Underneath sits an optimization engine, working out what staffing actually needs to look like, not what feels roughly right. Then the reality of the workforce itself. Current staffing, sickness, annual leave, turnover, trainees coming through the pipeline. Forecasting demand without forecasting your workforce is only half the picture. Diagnostics and procedures are configured in the same detail. Because this connects to operational hospital data, the simulation isn't working from assumptions, it's working from how this service actually runs. Now we bring it together. Choose a planning scenario, a simulation duration, the pathways involved, demand assumptions, capacity assumptions. From here, you can run as many what-if questions as you need, and get an answer to each one before committing to it in real life. This is where it runs. Not a formula, a simulation. Thousands of individual patients moving through the service in real time, each one tracked, each delay, each resource constraint, each clinical decision captured as it happens. This is discrete event simulation, and it's what separates this from a Markov model, a Monte Carlo run, or a spreadsheet built around averages. This captures how the whole system behaves when it's under real pressure, and layered on top, the platform's AI is predicting outcomes as it goes: mortality risk, deterioration, readmissions, heart failure risk, disease progression, future demand. So decisions can be made ahead of a problem, not in response to one. And here's the output: current state against future scenario, side by side. Waiting times, patient outcomes, workforce, capacity, cost, productivity, diagnostics, the operational and strategic picture in one place. For a hospital or an integrated care system, that's service redesign, capacity planning, and workforce decisions grounded in evidence. For pharma and biotech, the same digital twin supports health economic outcomes research, HTA submissions, payer conversations, and launch planning, built on how patients actually move through care, not how a trial assumed they would. For clinical development teams, it's trial planning, protocol design, and site selection, tested against a realistic pathway before a single site opens. All of it runs in a browser. No simulation software to install, no license to negotiate, nothing standing between the question you're asking and the answer. Because once you've built a digital twin of a healthcare system, you're no longer guessing what happens next. You already know, and that changes what better care and better decisions actually look like.